Welcome to the new session of Dr. Live by A+A. Today, we'll be focusing on real-world experience with CAR-T treatment in France. For those unfamiliar with A+A, we are a physician-led global healthcare market research firm headquartered in Lyon, France, with offices in New York, Paris, London, Munich, Bucharest, Shanghai, Hong Kong. My name is Christine May, and I am Vice President. It's my pleasure to introduce the moderator for today's session, Charles. Charles is Business Unit Director for International Project. Charles has over 20 years of healthcare market research experience on both client side and agency side. He is managing multiple patient chart-based studies in hematology, including but not limited to multiple myeloma, AML and other lymphomas, as well as projects for solid tumor and biologic markets. Before we get started, some housekeeping items. All participants will be mute throughout the session. We do invite you to ask questions by using the Zoom chat function at the bottom of your screen. And now, over to you, Charles.
Thank you very much, Christine. Welcome, everyone. I'd like to extend a warm welcome to our clients for joining today's Dr. Live session, where we'll be discussing how patients are considered for referral and treatment with CAR-T therapy, as well as barriers to treatment, unmet patient needs, and much more. Our guest speaker today is Dr. Thorsten Braun. He is a professor of clinical hematology working at Avicenne Hospital in Bobigny, which is an AP-HP hospital who does not perform CAR-T therapy yet. He has to refer his patients for CAR-T therapy as and when is needed. His main specialty is leukemia, but he also treats multiple myeloma patients and lymphoma patients. Dr. Braun, thank you very much and welcome for joining us. Just to dive into the subject matter immediately, could you please start by telling me what type of patients do you refer to CAR-T therapy other than multiple myeloma patients?
Yeah, thank you for this invitation, and I will answer to this question. So we follow generally the label of CAR-T cells. So that means that we identify younger fit patients, generally patients less than 70 years, who are in a third-line setting of large B-cell lymphoma. Those patients are a real problem in real life and clinical practice because those patients have aggressive disease and needs to be in a CAR-T program and the discussion to a treatment, a specific treatment after the second line treatment. And they progress after this treatment generally, and then we have to identify a CAR-T program to offer to these patients. So there are some fewer lymphoma patients which have now patients with mantle cell lymphoma who might benefit also from a CAR-T program, but this is rather a rare indication. So generally it's the problem of younger fit patients with large diffuse B-cell lymphoma.
Do all the newly presenting patients that you see already have a diagnosis, or are you ordering biopsies and tests to make the diagnosis yourself?
Generally, most of patients we treat in our center will be diagnosed. So the general entry of this patient is with polyadenopathy, and we diagnose the lymphoma, and then they are treated here. But we have also sometimes patients with a biopsy in a clinic, which is a private clinic, where the biopsy has been done with the histology, and then we do the workup for the extension, bone marrow biopsy, PET scan, and all these things necessary. But most of our patients will also be diagnosed in our center.
Right. Dr. Braun, focusing on multiple myeloma now, what type of multiple myeloma patients have you personally referred for CAR T therapy?
Oh, so the problem of multiple myeloma patients is generally that they all relapse. So we have an active cohort with I would say 1 to 2 indications per month for CAR T-Brom, which is also the same what I said for the large B-cell lymphoma patients before. Those patients are younger, fit, and they have received the main drugs for multiple myeloma treatment, including antibody therapy and second generation proteasome inhibitors. So those patients have received generally 3 lines of treatment, and so they can be referred to a patient name program actually active in France, which can be offered to patients when they have received the main myeloma treatment before, and they are rather fit patients, or just until recently there were clinical trials running testing CAR T in multiple myeloma, and we could try to offer to a CAR T center with a CAR T program participating in this trial to propose those kind of patients. This kind of patients, excuse me.
And once a patient is actually assessed by the treatment center as a candidate to receive CAR T therapy, how are you notified of that?
Generally, we are in a very close relationship with our colleagues in the CAR T center. So we are really informed nearly in real time what if the patient is eligible for the CAR T program or not. And what is very important for us is that we have with one center now a board where we discuss the patients in person. After the COVID problems, we can go to see our colleagues actually, and then there's a general okay for the indication. Then the patient is seen by the referent physician if he is suitable for the CAR T program, and we are nearly immediately in the 24 hours after the patient has been seen by the reference center, we are informed which kind of treatment is desired to bridge to the CAR T if there's if necessary, or if he's not suitable for a CAR T program.
Okay, and talking about suitability, what characteristics would a patient have or not have to present for you to consider them to be a good candidate for referral to an ATC center?
Yeah, generally we verify before proposing the patients to the center if the patient is fit, has a low comorbidity index. That means that he has no main organ dysfunction limiting his access to the CAR T program, and on the other hand that he has received the treatments before necessary for the inclusion in the CAR T program.
Right, and on a much more practical aspects, do things like patient social network or financial ability or accessibility to the hospital or things like that, do these come into the equation at all?
I think the patients are really in confidence with our center. So the patients receive the treatment, and if we discuss a CAR T program with our patients, they already followed our proposal to go into a CAR T program. On the other hand, there's a very active program in France, which is driven by the interests of patients, and so they are aware. Generally, the patients with multiple myeloma are very aware of treatment innovation, and so they might also ask if they are suitable for a CAR T, and then we have to explain that you need to be treated with carfilzomib, daratumumab before entering such a program, and so they are quite confident with this. The problem is that actually the CAR-T program is rather late. That means in the fourth line of the treatment of the multiple myeloma, and often, especially for younger patients, there's a really aggressive disease, and to restabilize the pathology before the CAR-T program might be really an issue.
And how do patients react to the proposed CAR-T treatment? What questions do they tend to have most often?
It's generally a concern about toxicity, hospitalization, duration of hospitalization, especially in an environment they don't know before, because they are in our unit, they have been treated here. Most of patients generally in an outpatient setting, except for the intensive treatment for autologous hematopoietic stem cell transplantation. So they know nurses, physicians, and that means that there are concerns about the new environment and treatment intensity, toxicity in comparison to the autologous stem cell transplantation, and the duration of hospitalization to the treatment, and maybe late effects. But on the other hand, the patients are aware that if we propose this kind of treatment, that it is the best way to do, because the other treatment solutions are restricted. So we discussed this, and generally almost all patients accept to go to the CAR-T cell program if it is possible.
And with a patient, sorry.
There's one remark that it is that we explain to patients that maybe the CAR-T will never be realized because of the progression of the multiple myeloma, and that it is quite difficult already to control the disease before the CAR-T program.
Okay, and talking about this particular severity, about patients, with patients who were not estimated to be eligible for stem cell transplant, for example, would these patients be eligible for CAR-T?
This is a difficult question, because it might be that we have patients in a very bad condition initially, that they may improve after treatment of multiple myeloma, but generally we try to offer an autologous transplant before. But on the other hand, there are some patients where we can't mobilize the stem cells before, and so they are younger, fit patients without solution for autologous hematopoietic stem cell transplantation, which might be referred to a CAR-T program in this setting.
Okay. When patients are actually referred and they need to sort of go, on things like bridging therapies and so on, how is it decided on who administers the bridging therapy? Is it yourself, or is it the treatment center? How does that work out?
Yeah, generally we ask the CAR-T center which kind of bridging therapy they prefer, but the bridging therapy is generally done in our center.
Right. Okay, cool. And sort of a final question probably we have for you today is, what type of support do you expect from the pharma industry to help you better manage these patients, to help you actually, really be on top of the situation with that?
So I think what could be interesting is a kind of checklist which is easily to understand in the different scenarios. If we can go directly to the CAR-T program, exactly which kind of treatment patients have received already which means antibody treatment, proteasome inhibitor treatment, and that it is really sometimes necessary to have a bridging therapy, but it needs to be very precise and very close to the expectations of the patients. It's not too complicated. But I think it is not easy to elaborate things like that. It needs really the experience of the patients, experience of the treatment center, the referring center, and the CAR-T center. But a short checklist with some key points could be helpful from the pharma industry to help the patients to understand.
Thank you. Thank you very much for all that. It's been very insightful. I'm going to call on Christine now to see if we have any additional questions for Dr. Brown. Christine, have you had any questions?
Yes, I have one question, which is about the patient follow-up after receiving CAR-T therapy. What are the main difficulties at this stage? Who is managing the follow-up of the patient?
Yeah. Follow-up of the patients after receiving the CAR-Ts needs some specificity, which means that you need to verify the expansion of the CAR-T in the peripheral blood. So the follow-up of the patients is done at 100% in the CAR-T center.
Okay. So thank you, Dr. Brown, for sharing your experience with E+E and our client in the pharmaceutical industry. Thank you to our partner, Medicis. If you missed, this is to the audience, if you missed former Dr. Live session, you can log on our website, epleseresearch.com, and get access to the recording of previous session. Thank you very much.